Alzheimer's disease. Lesson 2 of 6. Definition. Dementia is a broad term for slow progressive cognitive decline. There are many different types, including Alzheimer's disease AD and vascular dementia. Alzheimer's disease is a chronic, progressive, degenerative disease of the brain and is the most common form of dementia with a familial tendency. Alzheimer's disease accounts for 70% of dementia in Canada and is most prevalent in older adults, with risk increasing with age. Etiology and pathophysiology. Similar to MS and PD, the exact etiology is unknown. Age is the most important risk factor, with only a small percentage of individuals under the age of 60 developing it, which is known as familial Alzheimer's disease early onset. There are characteristic findings with AD, which include amyloid plaques, clusters of insoluble organic deposits, neurofibrillary tangles, abnormal collections of twisted protein threads, and gradual loss of connections between neurons resulting in brain atrophy. Modifiable risk factors. Risk factor, reducing risk. Medical conditions, type 2 diabetes, stroke and TIA, hyperlipidemia, hypertension, obesity, and chronic inflammatory conditions, healthy lifestyle choices to reduce risk of developing. Appropriate treatments when conditions are present. Head injury, use of recreational or sport helmets, fall and concussion prevention, use of seat belts, late life clinical depression, identification and appropriate treatment of depression. Health lifestyle choices, and appropriate support for traumatic experiences and stressful life events. Social isolation and active social life. Volunteering. Participation in intellectual activities. Educational attainment policies and programs to support young adults' completion of secondary and post-secondary education. Lifelong learning programs. Midlife hearing impairment, reduce occupational noise exposure, reduce smoking, use auditory amplification, including hearing aids or cochlear implants. Clinical manifestations. Individuals with AD experience a gradual progression of symptoms. Remember the 8 days of dementia. The rate of deterioration in AD is highly variable from individual to individual. AD may be preceded by mild cognitive impairment, which is a risk factor for developing dementia. Easily distracted. Deficit. Definition: possible effects on behavior. Amnesia, initially loss of recall of events, but eventually loss of long-term memory, repeated questions. Disorientation, misplaces items. Aphasia, loss of ability to express and comprehend spoken and written language, social withdrawal. Loss of ability to communicate in a second language. Misunderstandings, inability to communicate needs, agnosia, inability to recognize common objects or faces of familiar people, including themselves, using wrong objects, suspiciousness, mistaking self in the mirror for someone else, apraxia, loss of ability to initiate purposeful movement, difficulty understanding terms such as back, front, up, and down, difficulty performing ADLs, inability to perform previously learned tasks, altered perception, misinterpretation of sensory information, loss of depth perception, visual distortions, fear when walking downstairs or sitting down, misinterpreting objects, bumping into things, falls, apathy, loss of drive or initiative, sitting in one place for long periods, inability to initiate conversation or activities, but participates when invited by someone else. Anosognosia, loss of ability to realize that there is a problem with memory and functioning resistance to care. Self-protective behaviors, irritability, attentional deficits, decreased ability to pay attention, and focus inability to complete a conversation. Easily distracted. Wandering. Exit seeking, constant requests for help, pacing, grabbing. Behavioral and psychological symptoms. Behavioral and psychological symptoms of dementia are often responses to something in the patient's environment or perceived threat that results in a responsive or self-protective behavior, which includes appetite changes, slow or excessive movements in speech, agitation, pacing, wandering, exit seeking, constant requests for help, pacing, grabbing others, yelling, screaming, inappropriate behaviors, worry, depressed moods, euphoria, fear, apprehension, panic, tension, diagnosis. Diagnosis is based on the patient's history, including interviews with the patient and caregivers, physical examination, and brief cognitive tests. Diagnostic tests will be performed to rule out differential diagnosis and include lab tests, CBC, electrolytes, TSH, T3, T4, CA, fasting glucose, and B12 levels. Imaging can be performed, but it will not show any plaques or neurofibrillary tangles. These can only be seen upon tissue examination after death. Several different cognitive tests, such as the Mini Mental State Examination, the Montreal Cognitive Assessment, and the Canadian Indigenous Cognitive Assessment, to assess an individual for the presence of dementia. It is essential to use these tests in the early stages of the disease, as it is easy for an individual to compensate and for symptoms to go unnoticed. Treatment. Interprofessional care is required, as there is no cure or medication that can reverse the effects of the disease. ED is the only form of dementia that medications that affect cognitive decline have been approved for. Pharmacological treatment. Medication symptoms relieved adverse effects, precautions. Cholinesterase inhibitors, donepezil, galantamine, may stabilize or improve cognitive function and enhance the patient's functional abilities. Extended release formulation of galantamine may cause severe skin reactions, increase the risk of bradycardia and syncope, nausea, vomiting, diarrhea, vivid dreams, and leg cramps. N-methyl D-aspartate receptor antagonist, memantine, appears to protect the brain's nerve cells against excess amounts of glutamate, which is released in large amounts by cells damaged by AD, diarrhea, agitation, and insomnia. Antipsychotic medication. Atypical antipsychotic medication preferred, such as selective serotonin reuptake inhibitors. Management of BPSDs. Monitoring for effectiveness and for adverse effects. Nursing assessment. Person-centered care is important when working with AD patients and their caregivers. Following a person and family-centered care approach, the focus should be on the person's experience and their uniqueness. The nursing assessment should focus on the patient, family, caregivers, and their physical and social environment. Assessment includes mental status, cognition, neurological symptoms, psychiatric symptoms, functional assessment of ADLs, communication abilities, obtain information from both the patient and their family or caregivers, possible priority concerns, problems, falls and risk for injury, self-neglect or harm, cognitive impairment, nutritional deficits, infections, oral hygiene concerns, elimination problems, eating and swallowing difficulties, nursing goals, maintaining physical health, retaining functional abilities as long as possible, enhancing or stabilizing cognition, eliminating pain, preventing or minimizing responsive and self-protective behaviors, supporting emotional and physical well-being, reduce caregiver stress, and maintain health and well-being. Nursing interventions. Interventions provided are going to focus on the needs of the patient and family or caregiver. It is crucial to ensure patient safety by reducing the risk of falls, ensuring a safe, monitored environment, and, if the patient wanders, putting safety measures in place to ensure that the individual is observed. Education, such as gentle, persuasive approach training, can be provided to loved ones or caregivers to better understand behaviors and how to safely handle different situations that may arise. Take time to consider multidisciplinary team members that the individual should be referred to, such as a speech-language pathologist, physiotherapist, occupational therapist, massage therapist, dietitian, social worker, psychiatrist, and pharmacist. Regularly assess for caregiver burnout and provide resources available. The nurse also needs to closely monitor the ability of the patient to perform ADLs. As this ability declines, it is important to ensure that they receive appropriate oral and skin care to prevent breakdown, decay, and the risk of infection. After providing interventions, the outcomes must be evaluated to determine their effectiveness. If the outcome does not improve, consider alternate interventions and approaches.